All right. So welcome all colleagues to the Comprehensive Neuroanatomy Educational Program. We'll be having Module 3, Webinar 8, and Dr. Ravi Shankar will be the speaker, and he's talking about major ascending and descending tracts in the brainstem. So if you like, we can start. Please share your screen, Dr. Ravi.
Thank you.
Thank you. So as I said before, Abdullah won't be able to come due to his case.
Yeah. Good evening, everyone. And from all time zones, thank you for inviting me over here. Especially a big thanks to Professor Ahmed, Professor Buzar, and the team of YNS, WFNS-YNS Neurosurgery Forum, and Pakistani Society for Neurosurgical Surgeons. So I think they have been continuing this webinar, this educational webinar for a prolonged period of time, and that's a commendable effort that you are really doing. So, and especially bringing forth these neuroanatomy webinars is kind of taking us back to the basics of neurosurgery, so we can learn. Sometimes we tend to forget this neuroanatomy part of it while we are doing our surgical part of it. I thank really the organizing team for inviting me over here. So my talk for today is ascending and descending tracts in the brainstem. I think that's an not a very interesting topic, but I'll still try to summarize it as interesting as possible for all of us. So what is a brainstem? Brainstem is nothing but a kind of a bridge between the forebrain, cerebellum, and the spinal cord. So it acts as a conduit between these forebrain, cerebellum, and spinal cord. And it has made various nuclei, fiber tracts running along this small path of brainstem, and various cranial nerves nuclei take origin from that. And the if we really kind of divide the function of brainstem, it is kind of as it is called as stem of life. The brainstem is really the stem of life because it houses the major cardiovascular, respiratory, blood pressure control centers in that. It also houses various cranial nerve nuclei and also kind of acts as a bridge for transmission of fibers from forebrain and cerebellum to the spinal cord. So if you really talk about the history of brainstem, so this is the PubMed search that I did for this article. And if you really see in the first half of 20th century, we hardly see any papers on the brainstem kind of a thing, because that was such a forbidden area where people really didn't want to go or do some work upon it or do some research work upon it, because due to the dense neurovascular structures, fiber tracts that were present in that small area, the small confine of brainstem, that was kind of taken as a no man's land where people didn't dare to go upon, for the fact that even a slight change in the morphology, physiology, anatomy of it produced dense complications which were kind of very unforgiving for the patient as well as for the surgeon. So that's why for the first half, we can always take that the brainstem was in no man's land for neurosurgeons, neurologists, and all those who are interested in the study of brainstem. But now, because we have now started studying the anatomy, physiology, and morphology of it, we really know much about it. And now we can really go ahead and do treatment upon the brainstem. But for that, we have to really understand the basic of the brainstem, that is the anatomy part of it. So the brainstem can be divided into three areas from dorsal to ventral. Mainly, this classification is based on embryological origin of the brainstem, the white matter, gray matter organization that is there in these areas, and the functional division that is there in this part of the brainstem, that is tectum, tegmentum, and basal portion of the brainstem. But if you really look into the anatomical classification of brainstem, that is from rostral to caudal, it is divided into midbrain, pons, and medulla. So this is the classification that we really talk about of the brainstem, that is midbrain, pons, and medulla. And we study all the anatomy based on this classification. The tectum is so if we kind of combine these two classifications, we see that the tectum is mostly limited to the midbrain, Most of the medulla is made up of tegmentum, and the basal portion mainly forms the pontine part of the brainstem. So if we have to study the anatomy of the brainstem, it is usually done at various sections. So the sections that we really that we take into the study of brainstems in the various parts of brainstem, that is midbrain, pons, and medulla, is at the level of medulla. We study this anatomy at three levels, mainly at pyramidal decussation, at sensory decussation, and at the level of the floor of the fourth ventricle. If we study the pontine part of the brainstem, that is at two levels, that is the lower and upper part of the pons. And if we study midbrain, that is again at two levels, that is at the level of superior and inferior colliculus. So going down from below upwards, I am taking this liberty from going from below upwards for the fact that in the last talk by Professor Victor, we had this beautiful talk on the pathways in the spinal cord, and we'll be taking this forward from there. So the first area that we study is the lower medulla at the pyramidal decussation. And this is not something new. If we really have studied the spinal cord sections and the anatomy, we'll see that the medulla at this level is kind of very similar to the somatotropic organization which is seen at spinal cord level. So it resembles spinal cord in having same three phenoculi and same tracts. So if we divide this medulla into the gray matter and the white matter, we see that in the gray matter, the decussating pyramidal fibers separate anterior horn from central gray matter. So this is the pyramidal decussation that we are seeing, and it divides the gray matter into two halves, a small anterior half and the large posterior half of it. So this divides the gray matter into central gray matter and a anterior horn. Separated anterior horn forms spinal nucleus of the accessory nerve laterally and supraspinal nucleus of the first cervical nerve nucleus. Again, nucleus gracilis and cuneatus are continuous with the central gray matter at the posterior part of the medulla at this level. Laterally, central gray matter is continuous with nucleus or spinal tract of the fifth nerve at this level. If we study the white matter part of the medulla at this level, we see that there are pyramids anteriorly from which their name has been taken out. That is the pyramidal decussation at this level, where the pyramids kind of decussate into the spinal cord arrangement that is seen down below. The pyramidal tract decussation, where fibers from pyramid run backward and laterally to reach lateral white column of spinal cord to form lateral corticospinal tract, which is the structure that is seen in spinal cord. This is the organization that will go down below in the spinal cord. Fasciculus, gracilis, and cuneatus occupy broad posterior white columns at this level. So coming to the next kind of level that we study the medulla upon is the level of the sensory decussation that we have. At this level, the gray matter is nucleus gracilis and nucleus cuneatus, which are much larger and separate from central gray matter. Fasciculus, gracilis, and cuneatus end in these nuclei. Lateral to cuneate nuclei is accessory cuneate nuclei, which relay unconscious proprioceptive fibers from upper limb. The nucleus or spinal tract of fifth nerve is also separate from central gray matter at this level. The central gray matter at this level has various cranial nerves or the last cranial nerve nuclei of hypoglossal, dorsal nuclei of vagus, and nucleus of tractus solitarius at this level. The white matter organization at the level of sensory decussation at middle medulla is nucleus gracilis and cuneatus give rise to internal arcuate fiber, which cross to opposite side and form medial lemniscus. So this decussation at this level of the sensory tracts give rise to the name of what we call as the level of the name, that is the level of the sensory decussation that we are seeing. In this lemniscus, the body is represented with head posteriorly and feet anteriorly. Pyramidal tracts lie anteriorly again at this level. Medial longitudinal bundle lie posterior to the medial lemniscus at this level. Spinocerebral pathways, lateral spinothalamic, and other tracts lie in the anterolateral area at this level. So I'll be just rushing through the fiber tracts at various levels and how do they really kind of dictate our teaching or going ahead in doing our clinical works will be dealt in the coming slides. So just kind of bear with me in learning all the fiber tracts pathway and the various nuclei that we see at various levels. So now coming to the very important part of it, that the medulla at the level of the fourth ventricle. So this is kind of very intricate and a very kind of an dense area where we see various structures at the floor of the fourth ventricle in the upper medulla. The gray matter at this level has nuclei of various cranial nerves in the floor of fourth ventricle, that is hypoglossal nuclei, which is in paramedial location, the dorsal nuclei of vagus, which is lateral to the 12th nerve nucleus, nucleus of the tractus solitarius, ventrolateral to the dorsal nucleus of vagus, and inferior and medial vestibular nuclei, medial to the inferior cerebellar peduncle. Nucleus ambiguous lie deep to the reticular formation of medulla and give origin to 9th, 10th, and 11th cranial nerve at this level. Dorsal and ventral cochlear nuclei lie on surface of inferior cerebral peduncle and receive fibers from cochlear nerve. The nucleus of spinal tract of fifth nerve is in dorsolateral part at this level. Inferior olivular nuclei, the largest mass of the gray matter seen at this level, is responsible for producing elevation of the olive and resembles a crumpled purse. So this appearance that you see is like a crumpled purse at this level, and close to it are medial and dorsal accessory olivary nuclei. Arcuate nuclei, which is a fiber tract, is seen just anterior and lateral, anterior medial to the pyramidal tracts at this level. And various visceral centers responsible for respiration control, cardiac center for regulation of heart rate, and vasomotor center for regulation of BP, blood pressure are seen at this level. If we study the white matter path of the white matter organization at this level, we see that there is inferior cerebral peduncle occupies the posterolateral part lateral to the fourth ventricle at this level. And there are various fibers at this level which are coming out, for example, olivocerebellar fiber pathways, trimedullaris, and emerging fibers of the 9th, 10th, and 11th cranial nerve at this level. Now coming to the pontine part or the pons. Pons is again studied at two levels, at the level lower pons and at the level of upper pons. Pons has two parts. Again, as said in the earlier slides, pons has two parts. That is the ventral or the basilar part and the dorsal or the tegmental part. The ventral or basilar part is continuous inferiorly with the medullary pyramids and each side of cerebellum through medial cerebellar peduncle. Middle cerebral peduncle. And the dorsal or tegmental part is a direct upward continuation of medulla, excluding the pyramids. We study lower pons, which is also known as the level of facial colliculus. We see that in the gray matter organization, we see there is this sixth nerve nuclei, and there is a hump all around it produced by the fibered pathway of the facial nerve, which gives the eponymous name of facial colliculus at this level. The sixth nerve nuclei lie beneath facial colliculus. Seventh nerve nuclei lies in the reticular formation of the pons. Vestibular and cochlear nuclei lie in relation to the inferior cerebellar peduncle at this level. Spinal nuclei, again coming from medulla up till this level, lie in the lateral part. Other nuclei at this level are the salivatory and the lacrimatory nucleus. So these are the various gray matter structures that we see at this level. Coming to the white matter part of it, we see this large body, which is known as trapezoid body, lying just behind ventral part of pons and consists of fibers that arise in cochlear nuclei and is a part of auditory pathway. Medial lemniscus on the either side of midline just behind trapezoid body and is joined by anterior spinothalamic tract and is the upward continuation of the sensory pathway coming down from down below of the spinal cord. Lateral spinothalamic tract or spinal lemniscus lie lateral to the medial lemniscus at this level. Inferior cerebral peduncle lie lateral to the floor of fourth ventricle at this level. And the eponymous name that we get for what we get this name is the facial nerve forming this facial colliculus. The facial nerve fibers follow a peculiar course. So they kind of wind around the sixth nerve nuclei, and they produce a hump in the floor of fourth ventricle, giving the name of facial colliculus at this level. Now coming to the upper pons. So the upper pons is again the organization of gray matter and white matter. The gray matter at this level is very small and not much structures are seen at this level. The motor and the superior sensory nuclei of fifth nerve and a motor are seen at this level. The motor nuclei is medial and superior to the superior sensory nucleus. White matter, if we see, immediately behind ventral pons, we see transverse band of fibers. So this green structure that you see from medial to lateral are the fibers or the sensory fibers that we see in a chain kind of a thing. From medial to lateral are medial lemniscus, trigeminal lemniscus, spinal lemniscus, lateral lemniscus. The trigeminal lemniscus contains fibers arising from spinal nuclei of trigeminal nerve and are traveling to the thalamus to relay the sensory information. The lateral lemniscus part of auditory pathway formed by fibers arising in close relation to trapezoid body, superior alveolar nuclei, and the nuclei of trapezoid body is seen. The superior cerebellar peduncle lie dorsolateral to the fourth ventricle at this level. The medial longitudinal bundle is made up of fibers that interconnect the nuclei of cranial nerve 3, 4, 6, 8 and spinal part of 11 and coordinates movement of head and neck in response to stimulation by 8th cranial nerve. However, the majority of fibers of the medial longitudinal bundle arise in vestibular nuclei. So again, very confusing. So if we really kind of understand this fiber, it will be very confusing. So in the coming slides, I'll kind of give a mnemonic pathway of how to remember the various structures at various levels. Now coming to the midbrain part is again, as said in the earlier slide, is mainly formed by tectum, and there is a tegmental part of it also. But the whole tegmental and the crus cerebri from the cerebral peduncle, which connect the brainstem to the various structures in and around it. So if we study the midbrain, so again it is at two levels, at the level of inferior colliculus and at the level of superior colliculus. So at the level of inferior colliculus, the gray matter has is central periaqueductal. So it is kind of situated all along or in a circumferential path to the aqueduct. So this has trochlear nerve nuclei and the mesencephalic nucleus of the fifth nerve. And now we have this lateral lemniscus in the gray matter, which gives efferent fibers to the inferior colliculus. So this gives efferent to the inferior colliculus, which then relay efferent to the medial geniculate body, and they help in localizing sound. So whenever sound is coming from which area it is coming, so they help in localizing the sounds. Then we have this gray matter again in a band-like thing between the tegmentum or the crus cerebri or the tegmental part of it, which is concerned with muscle tone. Now coming to the white matter part of it, you see this whole white matter which is situated anteriorly has this crus cerebri, which contains in the medial 1/6 the frontopontine fibers, and in the lateral 1/6 the temporoparietal and the occipitopontine fibers. But in the middle 2/3 of it is the main part, which is the corticospinal or the corticonuclear fibers or the corticospinal tracts, which are the major motor pathways coming from up below going into the spinal cord. The tegmentum consists of ascending tracts, again the lemniscus that we studied in the earlier slide, medial, trigeminal, spinal, and lateral lemniscus are seen in the tegmentum. Superior cerebellar peduncle decussation occurs at this level. The superior cerebral peduncle decussates at this level. The medial longitudinal bundle is in relation to the trochlear nerve, and the tectospinal and the retrospinal tracts are seen at this level. So coming to the last cross-sectional study that we do is of at the level of the superior colliculus. So if we study the midbrain at superior colliculus, again it has a gray matter and a white matter differentiation. The gray matter has the nuclei of oculomotor nerve and the Edinger vesical nucleus in relation to the oculomotor nuclei. And this has also got the mesencephalic nucleus of the fifth nerve, which is again ascending up from the inferior colliculus. The retina and the other visual centers give efferent to the superior colliculus, which then gives efferent to the tectospinal tract. And these control reflex movement of eye and head and neck in relation to the visual stimuli that is taken in the visual cortex or the retina, and which goes back and relays in this way. There is a pretectal nuclei which is in superolateral relation to the superior colliculus. Optic tract gives efferent to the pretectal nuclei, which then gives efferent to the Edinger vesical nucleus, which is situated in close relation to this. This is an important part of light and consensual reflex that we see. And any damage to this pretectal nuclei causes what is a very kind of an well-known entity, that is the Argyll-Robertson pupil, used to be seen in earlier days, especially in syphilis or other conditions, in which the light reflex is absent and the accommodation reflex is present. Then we have this big nucleus that we see at this level. These receive efferent from various paths, that is the superior cerebellar peduncle, globus pallidus, subthalamic nucleus, cerebral cortex, etc. And then they give efferent to the rubrospinal tract, reticular formation. The major function of this red nucleus is in the control of the muscle tone. And there is this gray matter part, which is again seen as in the inferior colliculus, substantia nigra, concerned with the motor tone. So these all are red nucleus, and the fibers associated with it and the substantia nigra controls the motor tone in the body. The white matter part of it has again the crus cerebri, which has got the same somatotropic organization as seen at the inferior colliculus. The tegmentum has again all the same fibers, the lemniscal fibers as inferior colliculi, except the lateral lemniscus, which has terminated into the inferior colliculus and down below. The dorsal tegmental decussation occurs at this level, formed by the decussation of the tectospinal tract and the tectobulbar tract. The ventral tegmental decussation formed by rubrospinal tracts occur at this level. There is again that medial longitudinal bundle running from up, down, below, up. Tectum shows what we call as posterior commissure, which connects both the superior colliculus at this level. Very confusing. So if we really kind of go through all the level organization, it will make no sense to us, kind of very confusing to all of us. So this was a very important article that came by Gates in 2005, which he kind of concised all these pathways, and he gave a brainstem rule of 4, a simplified method for understanding brainstem anatomy and brainstem vascular syndromes for non-neurologists. I think it makes sense for the neurologists and neurosurgeons too. So what he said, that the basal portion, which is situated more anteriorly, and this is kind of as told in the earlier slide, it is the same part which has got the same functional organization, the gray matter, white matter differentiation, the functional organization, and it is kind of what we call as the physiological classification of it, not the anatomical classification. The basal portion has the fiber tracts, again 4 in number. All the things that I'll be telling in the coming slides are the rule of 4, in addition to the rule of 4 that was given by Gates in his article. So this portion has corticobulbar or corticonuclear tracts, corticopontine tracts, corticospinal tracts, and the arcuate nucleus, which is situated down below in the medulla, not in the whole of the pons or midbrain, but only in the down below medulla. So if you really think about it, all the fibers, the important fiber, the motor fibers are running in the anterior part of the brainstem, that is the basal portion. And if you really think about the surgical part of doing any brainstem surgery, you will hardly see any kind of surgical interventions that we do from anterior side, because all the fibers are kind of splayed on the surface of the brainstem in the anterior portion. and any damage to it will lead to devastating complications. We have some safe entry zone classification in the of the brainstem in the anterior part, but we'll see in the coming slides how we really kind of avoid damaging these all important structures when we go from anterior into the brainstem. The tectum, again, the physiological and anatomical classification is mostly limited to the brainstem, and it consists of 4 important structures, of which 2 are the levels at which we do the study. That is the superior colliculus, inferior colliculus, mesencephalic nucleus, which is coming from up below to the down below to the up, and the spinal lemniscus, which is the sensory pathway. So the anterior part is the motor part, the posterior part, the tectum part, or the posterior part is the sensory part of the brainstem. So again, now going with the brainstem rule of 4, we have 4 midline motor nuclei, 4 lateral motor nuclei, 4 lateral sensory nuclei, and 4 parasympathetic nuclei in the brainstem. So what are the 4 midline motor nuclei? Again, there are 3, cranial nerve 3, 4, 6, and 12. So these motor nuclei lie in the midline of the brainstem. There are 4, and these again they have that they are not by chance. So these are somatic motor nuclei arising from the brainstem, and these innervate muscles develop from the somites, which supply the extraocular and the tongue movement. So they have got an embryological basis of origin, and hence they are in the midline in the brainstem. There are 4 lateral motor nuclei in the brainstem. They are concerned with cranial nerve, trigeminal nerve, facial nerve, 9th, 10th cranial nerve, and the 11th spinal accessory nerve. Again, these have an embryological basis of their situation, their laterality, for the fact that they innervate muscles developed from brachial arches and supply muscles related to mastications and movement of face and neck. So then there are again 4 lateral sensory nuclei concerned with cranial trigeminal nerve, vestibulocochlear nerve, vestibular and the cochlear part of it, facial nerve, and the 9th cranial nerve. So there are 4 parasympathetic nuclei in brainstem, that is in relation to the cranial nerve 3, cranial nerve 7, 9, 10. 10 has got 2 nuclei, that is the nucleus ambiguous and the dorsal motor nucleus. Then there are 4 lateral tracts or fibers seen in the brainstem, that are spinothalamic, ventral spinocerebellar, rostrospinocerebellar, and the sympathetic pathway. So these are the 4 lateral pathways. And then I'll just kind of rush through this slide because will not go into the detail of it. There are 4 cranial nerves in the brainstem, again having 4 nuclei of it. So these are concerned with trigeminal nerve, facial nerve, glossopharyngeal nerve, and the vagus nerve. So these all 4 cranial nerves have again got 4 nuclei, again which are situated in the brainstem. So there are again then 4 major descending motor tracts seen in the brainstem, that is the vestibulospinal tract, medial and lateral, reticulospinal tract, rubrospinal tract, and the tectospinal tract. In the lower medullary part of the brainstem, we have 4 dorsal sulci, the posterior median sulcus, sulcus limitans, posterior intermediate sulcus, and the posterolateral sulcus, which we kind of, when we are doing the surgical intervention or the anatomical study of it in the relation to the floor of 4th ventricle, we see these structures. Then there are 4 elevations in dorsal medulla, gracile tubercle, fasciculus cuneatus, trigeminal funiculus, and the lateral funiculus. And then this is there are 4 cranial nerves up of pons, 4 in the pons, and 4 down below from pons. The first 4 nerves arise above pons, middle 4 in the pons, and the last 4 from the medulla. So again, the brainstem has got 3 peduncles which kind of join this brainstem to the adjoining structures, that is the superior, inferior, and the middle cerebral peduncle. So you see the superior and inferior kind of midline or medial part of the peduncle, and the middle cerebral peduncle is the lateral. And if you really see the surgical part of it, the majority of surgery that we do in the pontine or the pontine part of the brainstem, that's the most safest entry zone. You will hardly produce any deficits if we go through middle cerebral peduncle in any surgical intervention that you are doing on the pontine part of the brainstem. So then there are, again, like in the previous slides, we have three columns: posterior, lateral, and the anterior, which goes down below in the spinal cord in the same somatotropic arrangement. This brainstem has three communications: the peduncle, posterior commissure, and the colliculi to the brainstem. And these all kind of converged at the rule of 4 in the brainstem. For example, you have any problem, for example, in the medial part of the brainstem. So all the M's, the midline M's will be kind of involved. And if you have a lateral part of it, the lateral thing will be involved. So in kind of this, the medial syndromes has the cranial nerve 3, 6, 12, corticospinal tract, and medial lemniscus involvement. The lateral syndromes, L syndromes, have cranial nerve 5, 7, 8, 9, 10, spinothalamic and sympathetic involvement along with ataxia. So this is a kind of a broad classification to how we can really localize the brainstem syndromes based on the involvement of various nuclei, fibers, and the cranial nerves. And then we can kind of localize the site of the injury that has happened in the brainstem. But this is not kind of foolproof or 100%. For example, if you have basilar occlusion, you can have this combined medial and lateral picture, and that will be kind of very confusing. So you have to really kind of, in this era of radiologic, we don't really kind of go into the neurological part of it, but still it is a kind of something. If we are studying the anatomical part of it, this becomes very important. And why this all is very important? Exam for where we started for that brainstem in the earlier days was a no man's land where people usually don't dwell upon going upon. And if we see such lesions in our practice, and if we are really not knowing the fiber, tracts, nuclei, all the structure, the somatotropic organization of the brainstem, it is very hard to kind of go ahead and do surgical part of the treatment for such patients. For example, this is a child, 9-month child, who came to our clinic with this giant lesion. We really didn't think it to be a cavernoma to start with. Our first thing with that we really thought was an ATRT type of tumor. But this was a tumor that we operated upon, and this came out as a giant cavernous cavernoma in a 9-month-old child. Again, this is an cavernoma which increased over the period of time that we operated in the recent past. And this is an more challenging case. This is an operated case of cavernoma who came to us and then we operated upon. So if all you are planning to do these kind of surgeries, so you have to be very clear in how what is the arrangement of various things in this brainstem and how you can really safely navigate through those pathways, fibers, tracts to produce minimal or better still, no complication to the patient. And if you don't know, so this is the thing that will happen. So you'll be kind of lost. You'll be lost once you're going there. For example, how to kind of safely navigate through this. And for example, in the pre-era of the Google or the maps that we have, we used to stop at every nook and corner to ask if we are going into some new areas, that where we have to take a turn and all that thing. But once we have become smart with this era of navigation, maps and everything, and now we are we put this map in our vehicles and our cars, and they kind of safely navigate us to the desired location. And the same is with the study of the brainstem. So if we really know all these tracts, fibers, nerves, arrangement in the brainstem, you can safely navigate and produce minimal or no complication to the patients while you are doing the surgery. So if you really know that, you will select the right pathway or the craniotomy or the approach for the patient. For example, these are various craniotomies and the surgical pathways that we take to approach a brainstem disease, be it a brainstem glioma or vascular pathology or anything like that. So once we have taken these craniotomies and pathway, we reach to the brainstem where we have this dense aggregation of these various structures in ahead of us. And then if we are knowing the safe entry zone concept, so then we can really kind of open up the brainstem at the desired location to reach the brainstem with what we call as a two-point method, where the distance to be traversed to reach the location from the brainstem entry point zone to the target area, that is the lesion pathway, is the smallest, which creates the least amount of neurological problem in the patient. So various safe entry zone concepts in brainstem are in midbrain, pons, and medulla are like this. Again, I'll show in the. And if someone is really interested to learn about these all safe entry zone concepts, which has been kind of very much advocated by the Barrow Neurological Group in this article by Professor Spelzler is in YNS, and again an article by Professor Baskaya in Neurosurgical Reviews. So in midbrain, the various, again, because all the structures, all the major motor pathways were into the anterior part of the midbrain. So we really don't go anything from anterior part of it. The usual pathway that we take is the intercollicular region or the lateral mesencephalic sulcus to reach the lesions in midbrain. But if we have a lesion which is situated anteriorly, the anterior mesencephalic zone is a path that we take to reach the lesions in midbrain. In pontine, I think we have kind of settled upon till the time it is very much needed. The path that we really take is the middle cerebral peduncle. The middle cerebral peduncle is a very forgiving path to reach the lesions of the pontine region, because this path has really no neural structures, and you can really go and reach the lesion where you have the pathology upon and take out without producing any problems or deficits into the patients. In the pontine, you see that the most kind of used pathway is the floor of fourth ventricle to reach any pathologies in the area of the medulla. But while we saw in that anatomical study in the region of floor of fourth ventricle, we saw that the facial colliculus is just lateral to the midline, and it kind of produces an elevation into the floor of fourth ventricle known as facial colliculus. So, and posterior median sulcus approach, which is kind of just encroaching upon the medial longitudinal fasciculus, is the preferred pathway. But a still preferred path is an far lateral craniotomy and then going via a lateral medullary zone, which kind of creates the least amount of problem to the patients in reaching any pathology in the medullary part of the brainstem, is then kind of a preferred path that we do. So the two paths that we really take are the posterior median sulcus and the lateral medullary zone. And this is an pictorial organization by the Barrow Neurological Group, where they have kind of, and they are coming out with a book of 7 cavernomas by Professor Lawton in the coming future, where they have divided these all lesions into types, subtypes, craniotomy approach, triangles, and the safe entry zone concept that they have to take to reach the lesion without producing any deficit. Because we started from the fact that the brainstem was a no man's land to start with, and now we are doing surgeries upon brainstem, but we still don't forget that the brainstem was a no man's land in the near distant and if we are to do surgeries in brainstem without producing any complications, we have to really understand these fiber tracts, pathways, cranial nuclei, and then have to navigate upon those to reach our lesion. Again, as in the description, it was told that it is for young neurosurgeons and residents. So I'll tell, this is kind of a philosophical part of the presentation, that science is not sacrosanct. So whatever I have told or whatever we have studied upon is not sacrosanct. So you have to choose for example, we as a surgeons, we have to choose pathways, surgical trajectories, approach, anything based on the experience that we have, the art that we have learned, and to what we can do to the best of our abilities and capabilities. So we can see from many master neurosurgeons, they will produce magic. But then we have to really understand what is safest in our hands and what we have learned from these masters that we can really safely do from our hands. And then we should really know our abilities and capabilities to do what is best for our patients. So you have to really master the art of neurosurgery. So these are the down below three are my teachers from which I have learned this art of micro neurosurgery from Professor Mishra, Professor Hannes Nemi, who unfortunately is no more with us, and Professor Tani Kawa, and Professor Lawton, who is my virtual kind of a guru. So these are my masters who I have imbibed this art of micro neurosurgery from, and this is a very important kind of a very important mantra Professor Lawton has given, that your head, heart, hours, and hand have to be in the right place to learn the art of micro neurosurgery. And this 10,000 hour rule was often said by Professor Hannes Nemi. So that you have to give 10,000 hours to your art to become a master of it. So you have to learn the trade craft and the art of micro neurosurgery from a master's to become the not best, but good at your field. So what is the 10,000 hour rules? Is an rule that says that if you look at any cognitively complex field, from playing chess to being a neurosurgeon, we see this incredibly consistent pattern that you cannot be good at that unless you practice for 10,000 hours, which is roughly 10 years. If you think about 4 hours a day, but somebody has broken it down much further. For example, 18 hours a day, 5 days a week, 44 weeks a year, then it comes down from 10 years to 5.5 years. So better get started. Thank you very much.
Thank you very much, Dr. Ravi, for that's brilliant presentation. A lot of information, and the final slides is something we all need to note. But I just wanted to tell that, like you mentioned, we live in the era where navigation is one of the main tools for us. But probably what sometimes young neurosurgeons, me as well, we forget about clinical representation, neurological representation of the patient. So deciding when and how to operate the patient also depends on whether we have hearing loss, whether eye vision loss, or any motor deficit, sensory deficit. And according to that, we can decide, okay, total or subtotal resection. So for young people, they kind of maybe underestimate this point, but neurological representation is something we have to learn. And brainstem symptoms, brainstem, any syndrome, first of all, should come from the knowledge of how neurology starts, I think.
Yeah. For example, I didn't show you in those slides the second patient that we had in the cavernoma slide that I showed you. So that was a patient that we really followed up from year 2013, and we operated upon that patient in 2024. So from 2013, we observed the patient. It was for an innocuous headache that the patient got a scan done upon. And he had a very small pontine lesion in year 2013. So again, not me for the first time, that was from some other guy. He told exactly that what you're just saying upon, that the lesion doesn't dictate a surgery or a treatment to be taken upon for the patient. The clinical symptoms dictate. If the patient has a symptom uh, which warrants a surgery, and you know in your heart that you will not produce any more neurological deficit to the patient, then only you should venture upon doing a surgery for such patients. For this patient was followed from 2013 to 2024, and when he developed facial palsy and increasing hemiparesis, that we operated the patient upon. So the clinical symptoms definitely do not guide you, but they dictate you for any kind of intervention that you do on the patient.
Right. Thank you so much. Dr. Aisu, would you like to?
I would like to thank you, Dr. Ravi, for your excellent talk. And on behalf of the WFNS Neurosurgeons Committee and Dr. Abuzer Güngör, I would like to express our gratitude. As a young neurosurgeon, for me, it was an impressive talk, of course. And I had the chance with working with Professor Ture and Abuzer. And I would like to ask a question actually, because they always says that since the brainstem has dense network of white matter tracts, nuclei, and vital structures, and so on, maybe the safe entry zone concept can be like reconsidered in the upcoming years. What do you think about that? I was wondering that.
That was I showed you in that slide. I think, first of all, I envy you. You are in the best hands of learning the art of brainstem surgery. You have Professor Ture, so I'll be very kind of dwarfed in front of him if I say something about brainstem surgery, because you have learned from the masters to start with. But again, in that slide that I showed you, that science is not sacrosanct. You have to really learn the tradecraft from the masters, then imbibe that art in you, and then you have to know down deep below that what is best in your hands, and then practice that art of neurosurgery. So this art of safe entry zone and this concept is an ever evolving thing that we have. For example, we had this 2-point rule, safe entry zone rule, the anatomical physiological origin of the brainstem rule. So all are kind of intermingled with each other. So they are not kind of one entity in one pole, one entity in other pole. They are all intermingled with each other. And you have to really kind of understand that where the lesion is, how the safe entry zone concept is there, where the fiber tract pathways are there. And then the most important, you have to know yourself deep down below. Yeah. So you have to know that, and then you have to really venture upon treating a patient.
Thank you. Are
Thank
there
you.
any questions from the audience as well?
No questions, just gratitudes.
I really didn't expect a question of this brainstem anatomy.
Yes, we are having that third model based on the brainstem anatomy, and almost no questions usually, because it's really hard to ask the question and to, first of all, completely understand the anatomy. So I'm not talking about the surgery even, it's just anatomy itself is very complicated.
I think, thank you for the opportunity. I again thanks the whole, and I will kind of request you to carry on doing this activity. So it's a very informative thing that you have been doing for the past many kind of thing, and I will request you to continue. I have been this avid listener of these webinars for so long, and this was a very pleasant thing for me to come on this August thing. Thank you so much.
Thank you so much.
Thank you.
Dr. Aisu, would you like to close the session?
Yes, thanks again for the all attending people and all our colleagues and professor. And thank you for moderating the session as well. And thank you, our speaker, again for his impressive talk. And good evening, everyone.
Thank you. Thank you.
Thank
Good night.
you.
See you next week. Thank you so much. Bye-bye.